And I'm going to touch upon some very simple aspects of evaluation, echo evaluation of mitral stenosis. Now we know that mitral stenosis etiology-wise, 99% cases which you come across will be rheumatic heart disease. There are some other rare causes like congenital MS, carcinoid heart disease, which is rare. Only 15% cases of carcinoid actually have left-sided involvement when they have large, if they have an ASDPF or very large output through the liver. Radiation is coming up in a big way. Um, you can have mitral annular calcification. There is another concept which you see a lot nowadays in aging population is what you call as an annular aging as well as annular calcification. And then you have SLE, etc. Even methysergide, etc. can cause mitral stenosis. Now, in a typical rheumatic mitral stenosis, you can see that these are the chordae. See how thick they are. Normally, they're really thin, thread-like structures. And in a chronic rheumatic heart disease, the smoldering inflammatory process makes them fibrotic, thick, and it leads to a so-called a fish mouth appearance of the mitral valve, and then, of course, associated changes, which we will discuss. Now, when we talk about the flow dynamics of the mitral stenosis, the flow dynamics basically uh, when there is a mitral valve which is stenotic, so there is a blood which is accumulating in the left atrium. There is a gradient between the left atrium and the left ventricle, which is what is one of the parameters through which we look at the severity of the mitral stenosis. And you're looking at the mitral valve geometry, the inlet geometry, and all these, the degree of flow acceleration, etc., will actually be responsible for the flow dynamics which are occurring proximal to the stenotic valve. So in mitral stenosis, there are left atrium to left ventricular pressure gradient, which pushes or drives the flow passively across the stenotic orifice in an abrupt way. So you have, it's like a dam which has been created in the left atrium, the accumulation of blood, and that kind of forces its way into the left atrium. And if you look at the 3D curved flow profile, it actually creates a hemielliptical isovelocity hemispheres, just like, and creates a pizza in these cases. Now, when you look at the echocardiographic estimation, there are some direct and some indirect ways of determining the severity of mitral valve area. So the best way is planimetry. Of course, from theoretical perspective, we will talk a little bit about continuity equation and PISA, which I just explained. And of course, pressure half time. In our day-to-day practice, there are two things which we almost always do, which is planimetry and pressure half time. And of course, the mean gradients that we calculate from the flow dynamics of the Doppler. Now, we have to understand that mitral stenosis will not give you clinical symptoms of typical clinical symptoms of dyspnea. The consequences of the hemodynamic consequences of mitral stenosis start appearing when the valve area decreases to less than 1.5 centimeters square. So physiologically, once or hemodynamically, once the mitral valve area falls below 1.5 centimeters square, you will start having patients with symptoms coming to you. That's why actually now the valve area of less than 1.5 centimeters square has been labeled as severe aortic stenosis, which I'll just show you. The traditional grading of mitral stenosis into mild, moderate, and severe is based on the mean pressure gradient estimation. So less than 5 is mild, 5 to 10 moderate, and more than 10 is severe mitral stenosis. The valve area being less than 1 being severe, more than 1.5 is mild. And PA pressures also more than 50 is suggestive or contributory to the severity of mitral stenosis. Now, this is an interesting concept which the American Society of Echo or the ACC had proposed, is based on the functionality of the mitral stenosis, the way it presents in clinical stages. So Just like all other staging, A, B, C, D, A being at risk of MS, where you see a bit of mild doming, but there is no hemodynamic changes. Then there is progressive mitral stenosis, where the mitral valve area is above 1.5, and there is some LA enlargement, but the pulmonary pressures remain normal. And of course, there are rheumatic changes. Then stage C is, interestingly, now when the mitral valve area falls below 1.5 centimeters square, it is called severe MS. If they're asymptomatic, walking around, not having any dyspnea, in their regular activities, even on climbing stairs, etc., they're called as stage C. They have all the rheumatic valve changes, commissural fusion, diastolic doming, but they have been labeled as severe MS. Less mitral valve area less than 1 is labeled as very severe MS, and here the LA enlargement occurs, the PA pressures go above 30. And then you have stage D, which is symptomatic severe MS, where the patients come to you with similar profile, but they're symptomatic. And here, of course, everything is exactly the same as asymptomatic stage C, but here the patient has come to you with symptoms. Now, when we look at the echo evaluation, where the patient is, the first thing which you look at is the plaques view. And you can see a typical doming of the anterior mitral leaflet. The PML is fixed. The left atrium is enlarged. You could also actually look at the aortic valve, which is quite frequently involved in rheumatic heart disease. So associated valve abnormalities is very important. And you look at the subvalvular thickening. So these chordae can become very, very thick. So if you move the probe a little up and down, you can actually visualize the chordae in plaques view itself. So there is a primary orifice which gets stenosed, which is this one. And then there may be a secondary orifice narrowing, which is downstream, which is at the level of the subvalvular apparatus. So you can have a primary orifice or a secondary orifice narrowing in mitral stenosis. The primary orifice narrowing occurs because of commissural fusion, and that is the commissural fusion is the one which gives rise to the doming part. In M mode, though more or less has very little value, but probably what you would probably just recall is that there is a reduced EF slope, the leaflets appear thickened, and there is a paradoxical motion of the PML towards the AML. So you can see a fixed PML, very flattish PML, and the AML is, of course, the EF slope is reduced. And this is a 4-chamber view. Again, you can look at the subvalvular apparatus here. There is doming of the AML, fixed PML. There is some LV dysfunction also, which is seen commonly in patients of mitral stenosis, which are chronically stenotic over a period of many, many years. And there is a trivial MR in this case, and of course, a flow acceleration. You can actually see the PISA here in the flow across the mitral valve. Now, very important is the commissures. Now, when you visualize the short axis, you are going to look at the mitral valve. So how do you actually come to the tips? Now that you have x-axis, you can actually have orthogonal, you can cut the tips of the mitral valve very well in the advanced echo machines. You have multiplanar imaging, which is available. Hence, the commissures can be very well visualized in short axis view. And for those who don't have advanced echo machines where you can use an X-plane, you could, what I do is that you go down towards the papillary muscles and you come up. So as you start coming up towards the base of the heart, that's where the mitral valve is. From the apex, you come towards the base of the left ventricle. You'll start seeing the leaflets. When you can see both the leaflets together, that is the tip of the mitral valve, and that's where you should be measuring or planimetering the area in mid-diastole. Now, in this view, these are the commissures which you can see, the anterolateral and the posteromedial commissures. And if they have a lot of calcium, so you can see these specks of calcium which are there. But if the calcium is centered or close to the commissures, Then when you are doing balloon mitral valvotomy, these patients, if the commissures become extremely hard and unflexible or unpliable, and the mitral valve is likely to tear open when you are doing BMV. So commissural calcification is a very important thing which you must look into whenever you are looking at planning to do balloon mitral valvotomy. Subvalvular apparatus again is very, very important because it guides the choice of therapy that you're going to do. If you have significantly affected the subvalvular apparatus, it is better to send the patient for surgery rather than for BMV. Now, there is a lot of, when we were studying, there is a lot of emphasis on scoring of the valve morphology. And yet, in your clinical practice, how many of us actually sit down and calculate a Wilkins score, or there are at least 5 other scores which are there? And the reason is that none of these scores are perfect. Now, the most commonly used ones is the Wilkins score. You also have Cormier score, and there is a recent publication on 3D scoring as well. You have Chen score, Reed score, and Nobuyoshi score, which actually looks at the commissures as well. But let's talk about the more common Wilkins score. Now, the most commonly used scoring system, which is the Wilkins, is depending, the parameters which we use are the leaflet mobility, its thickening, leaflet calcification, and state of the subvalvular apparatus. Now here, one thing which is straight away missing is the commissural part. It is underreported, not very well defined. If you ask me, commissural fusion or calcification is something which is of utmost importance. Anyway, each of these parameters can be judged between 1 to 4. So total score can be 4 to 16, maximum being 16. A valve is considered suitable for BMV if it is less than or equal to 8. And this is the Wilkins or Boston score, which was actually published in 1988. And a lot of modifications have come up, but it looks at the mobility, thickening, calcification, and subvalvular thickening. Even the calcification, if you look, is more, is saying, it's not really speaking specifically about commissures, but more about the leaflet calcification and what portion of the leaflet is involved and how much is involved, the extensiveness of it, the thickening between in millimeters, which we all know is very difficult to measure. So you can see that there is a lot of variability or observer variability which will come in whenever you are using these scores. So there are limitations that echo is unable to differentiate nodular fibrosis from calcification. The commissures are either underestimated or not included in those scores. It doesn't account for relative contribution of each of these variables, the 4 variables, which may contribute, differently in different settings. And there is a frequent underestimation of subvalvular disease because if you do not spend time and in different modified views, you may actually miss out on the extent of subvalvular disease. And it doesn't use the results from transesophageal echo or 3D echo, which is now freely available. Now, there has been a lot of debate about the utility of this cutoff of 8 for Wilkins score, and there are studies which have shown by Post et al. And Abascal et al. In 1990s, and they've said that even a Wilkins score of more than 10 in about 44% patients had pretty good results post BMV, and we see this every day in and out in our cath labs where we are doing BMVs even in a so-called Wilkins score of more than 10 or about 10 to 12. And even in Abascal, 32% of the patients who underwent BMV with a score of more than 8 had good immediate results. So a strict cutoff of 8 is not really valid. You have to look at the patient, the need for the BMV, the risk of surgery, the overall mitral valve morphology to decide whether you are going to send this patient for BMV or not. In a practical way, what I used to do in the cath lab as when we used to image is that if there is a heavy calcification of the valve, we would first underinflate the balloon initially so that you're not going to tear the valve up by overinflating. So you inflate the cuff, the balloon by about 2 or 4 notches down, And then in the second one, you can go up depending on the results of the first ballooning. And of course, there are certain contraindication to ballooning. I'll touch upon it right here before I move on. So you can have a large left atrial appendage clot, which is a contraindication, and these are common in mitral stenosis patients. Here, I would like to also mention a practical point that a lot of these patients will have atrial fibrillation, and the so-called use of NOACs is actually now restricted to the NOACs or like dabigatran, etc., can be used in all valvular heart disease more or less, except for moderate to severe MS, mechanical prosthetic heart valves, and bioprosthetic heart valve surgery up to about 3 to 6 months of surgery. About 3 months is what they say, but some papers are saying recommending a longer anticoagulation with warfarin in these cases. So barring these few cases, you can actually use NOACs in most cases of AF. Moving on, this is another case where you have a vegetation kind of a thing, an oscillating mass on the mitral valve with a thrombus. And these are also contraindication for BMV. This can be a vegetation or a thrombus. It looks more like a thrombus because you can see a thrombus which is lying on, there is mitral stenosis, of course, and this is that thrombus which is lying on the PML. Aortic valve is here, so it's at 12 o'clock position. This is the AML, this is the PML here. This is that oscillating mass which is actually attached to the thrombus on the PML. This is the same image. Then a very important thing is the evaluation of pulmonary hypertension. Now, the simplest way is to look at the TR jet. So you have mitral stenosis, the gradient is about 4. But if you look at the PA pressures, they're very high. It's approximately 44 plus the right atrial pressure. Suppose we take it as 5 or 6, it would be about 50 PA pressure, which is high. So obviously this patient this mitral stenosis is significant here if we look at the hemodynamic aspect of it. So here is an example where your gradient is indicated of mild MS by gradient. So mean PG is just 4, but your PA pressures are saying that there's something wrong. You have to look for high PA pressures. The PA pressures can be because of mitral stenosis, or it could be because of tachycardia, but then the gradient should go up as well. It can be because of, say secondary pulmonary hypertension in some of these cases. But basically this kind of a discrepancy is common, and we'll discuss this in subsequent slides. Now, planimetry is the method of choice in most cases, and when feasible, sometimes the valve is very distorted, and hence you cannot really do a very good planimetry in some of these cases. But it is actually the modality of choice immediately post BMV, or PMC as you used to call it. And the planimetry, otherwise, in most of the settings, planimetry and pressure half-time evaluation of severity of MS are complementary to each other. Continuity equation and PISA are more of a theoretical concept which you can read about, but it is hardly ever used for clinical assessment. Now, we have already discussed this, that when you're looking at the planimetry, you have to optimize the image, zoom it, lower the gain so that the leaflets don't appear too thick, and you may actually end up overestimating the severity or underestimating the area. And it should include the commissures, which basically means that you should go and trace the commissures like this, okay? Like this. You should not just end your planimetry like, without including the commissures. You have to include the commissures, go in, trace the commissure, come back, trace the commissure here, and then go back. So that is the right way to planimeter in mid-diastole. And if the patient has atrial fibrillation, the opening will be variable. So you have to take a mean of at least 5 to 10 readings. Most of us take about 5 readings and then average it out. Of course, 3D has come up in a big way. Most of us are doing 3D, and look at the beauty of 3D. This is a flip switch in your machines. So this is from the LA side. This is from the LV side. You can see a lot of chordae thickening here. The mitral commissures, while commissures are fused, look at the commissures which are fused here. So 3D gives you a very good idea about the morphology of what is happening. Now, here, of course, you have a case where you have mitral stenosis as well as tricuspid stenosis, and the mean gradient is about 3 in this case. And when you do a 3D image, you can actually look at the mitral stenosis as well as tricuspid stenosis very well on 3D. Now, what about the 3D derived mitral valve area on planimetry? Now, there are papers which have come up and which have shown that 3D echocardiography actually gives you a lower mitral valve area by planimetry when you're using the multiplanar reconstruction or MPR, which is an offline thing. So you have to actually spend some time aligning the tips of the mitral valve, and they are to be seen in the LV side. So this is how we create MPR and then measure the mitral valve area. Now, this has been, this paper actually showed that a lot of patients who were, so mild, moderate, severe. So these are the severe cases, moderate cases, and mild cases. By pressure half time, there were 4 patients who had severe MS. But when you did, say, 2D imaging, 10 of them actually turned out to have severe MS. And when you went on to 3D imaging, a lot of patients were actually recategorized into moderate to severe MS category. So a lot more patients were brought into the moderate category, moderate MS category, which means that 3D tends to give you a lower mitral valve area as compared to 2D. And it is being validated a lot. Now, the problem is that I want a simpler solution. So what I do is there a validity or is there a paper which says that whatever you are seeing on your screen when you're making a 3D imaging and you zoom it and then I planimeter it, rather than going for 3D quantification with MPR, if I just trace the zoomed view of the mitral valve, there is actually a paper which says that the direct planimetry of 3D zoom showed a moderate to good agreement with 3D quantification. So I think in future we would probably start including 3D mitral valve area by planimetry as well in our, say, echo reports. So planimetry, the strength is that it is relatively flow independent, load independent. It best correlates with the explanted valve area, which is the gold standard, if you ask me. So it is a very good method, but you have to do it properly, as we have discussed. The limitation is that it is difficult to measure the small area. You have to spend time and go up to the tips, make sure that you're cutting the tips not obliquely, but as much aligned as you can. And if there is a lot of distorted, thickened valve, then you are likely to make mistakes, or it's not going to be that accurate. And of course, post BMV, this is the only way you can use. Planimetry is the only way to assess the severity or the success of BMV. Coming on to transmitral pressure gradients. Now, the human psychology or psychology is that it needs very simple principles to work on a day-to-day basis. Look at the catheter derived. So in your cath lab, initially when the Golden formula, etc., were being used to make the assessment of mitral stenosis, we were using the mean the pulmonary capillary wedge pressure as an indirect measure of LA pressure, and the PCPWP to LV pressure gradient used to frequently overestimate the gradients and hence the severity of mitral stenosis. When the Doppler came in, and by pressure gradient is equal to 4V square by Bernoulli equation, we got peak pressure gradient and mean pressure gradient, okay? And it was shown that the mean pressure gradient actually had pretty good correlation with the invasive measurements, and it is highly reliable. So this is the cath data. This is during diastole, you have a E and an A wave, and this used to be this entire area under the curve. You can see this entire area used to give you the gradient by the cath data, and this is replicated in echo continuous wave Doppler image, very similar to what you get in cath. And then you can derive the pressure gradients. Now, the problem with pressure gradients are that they're highly dependent on heart rate and cardiac output. So suppose here the heart rate is 102, I give beta blockers or lanoxin, and the gradients can actually come down from mean 7 to about 3 or 4. Sometimes if there is a reduced cardiac output due to any reason, for example, in this case of mitral stenosis with mitral valve area being 1.2, the patient is in AF, you can see that the gradient is actually very low at 2 only because of reduced flow. So the pressure gradients can vary. If you increase the heart, if the patient is in fast ventricular rate with AF, or due to say anemia or thyrotoxicosis, pregnancy, the gradients will be high. So it is highly dependent on heart rate and cardiac output. Now this we have already discussed, the pressure gradient being highly dependent on, it's load dependent entity. And why do we prefer mean PG over peak? Because peak gradient is derived from the peak velocity. So if we go back so this is your, will be your peak velocity will be somewhere here, but the mean velocity is actually a VTI of the entire trace, which is much more accurate. So the peak gradient can actually be heavily influenced by LA compliance, the LV diastolic function, and the loading conditions. So suppose there is a patient who has, in this case, a peak pressure gradient is 25, while the mean is 15. So mean gives you a much more accurate and a stable gradient profile as compared to a peak PG. Now, suppose there is an associated mitral regurgitation. This also will give rise to higher gradients across the mitral valve because of the flow is increased. So in a case here where the mitral valve area is actually 2, the mean pressure gradient is just is 15. Because of the mitral regurgitation, it is much higher. Let's take an example. So this is a patient who has mitral stenosis. You can see there is a non-coaptation, hugely dilated left atrium. There is some LV dysfunction as well. Aortic valve is also stenotic. There is fixed PML, some doming and thickening of the leaflets. You can see that the mitral valve is not that stenotic. It's opening well. And there's significant mitral regurgitation and some aortic regurgitation. Now, when you look at you can see the severe mitral regurgitation in 4-chamber view. Look at the gradients. Gradient is 15, okay? But the mitral valve area was nearly 1.8 centimeters square. So this is one way where you could introduce discrepancy in gradient versus the mitral valve area. Here, look at the PA pressures being close to 80 or so, 80, 90. And if you add RA pressure, of course, it will be somewhere around 100. And these tell you this is mainly because of the LV dysfunction and mitral regurgitation. Coming on to pressure half time. Now, pressure half time is basically time required for the pressure gradient across the valve to fall from its peak value to half of the peak, right? So from various equations, a simple mitral valve area equation has been derived, which is 220 divided by the pressure half time in milliseconds. So the strength of pressure half time is that it estimates the functional mitral valve area. It is still feasible in distorted mitral valves where planimetry may be difficult. The pressure half time is not altered per se by the cardiac output MR or the diastolic duration and correlates well with invasive estimation. The problem is there are limitations of pressure half time because there are factors which can change changes the left atrial driving pressure. So you had to have ASD where the shunting is from left to right. There is low left atrial compliance, so the gradients will fall. There will be much quicker equalization of the gradients between the LA and LV, and hence the MVA will be overestimated. If the LV compliance if there is abnormal relaxation, left ventricular hypertrophy, AR or severe MR, this would also will also distort the pressure half time. So because of the high LVDP post immediate BMV, the pressure half time is not validated in post BMV situations. Because the LVDP is high, the pressure half time will be low and it will overestimate the mitral valve area. Let's take some examples as well. So suppose there is an atrial fibrillation, you have to average about 5 to 10 cycles of this. Take a cycle. So if you have this kind of 6 images, at least take 5 of them and then average out the gradient. Pressure half time should be measured in a longer cardiac cycle. So something not in this, but in this you should be measuring the pressure half time. And planimetry should be performed only if the valve opening is good. Then there is very important aspect, concept in pressure half time, is which is known as the bimodal deceleration slope. So sometimes you see this kind of a peak followed by a flattening of the slope. And if it were to take the initial slope, the pressure half time will be low and you would overestimate the area. But you are supposed to take this flattened slope and extrapolate it backwards and take out the pressure half time. So pressure half time um, will be higher in this case, and the valve area will be lower. So this bimodal deceleration slope you must be aware of, and do not make the mistake of taking the initial steep slope. The other is that if you have an AF, as I just mentioned, that don't avoid pressure half time in short cycles like this one, take it in a longer cardiac cycle. So this one is the right, not in this, because otherwise it will give you an erroneous result. Let's take an example of multivalvular heart disease. You have mitral valve stenosis here. There is some aortic valve stenosis as well. AR, there is some aortic regurgitation as well. In 4-chamber, you can see that. And so if you have a significant aortic regurgitation, the LV filling occurs both from the mitral valve during diastole as well as across from the aortic valve. And the pressure half time will be artificially decreased because the left ventricular pressure, end diastolic pressure will be higher. So there will be overestimation of the mitral valve area. So 220 divided by pressure half time is mitral valve area. So if your pressure half time goes down, the mitral valve area will be more. So for example, in this case, you can see that there is a significant aortic stenosis and aortic regurgitation. So you can see the mean gradient is just 6 because the LVDP is high, whereas the mitral valve area is actually 0.8. So you would expect much higher pressure gradients in this situation. And even by pressure half time, if you look at because the pressure half time is, the slope is steeper because of high LVDP, the mitral valve area estimation is higher at 1.4. So this highlights the discrepancy of, the gradients, the pressure half time derived mitral valve area and the actual anatomical mitral valve area. There is another case which I wanted to show is, look at the mitral valve. This is completely distorted. There is multivalvular involvement, severe MR, severe AR, severe AS. So this is a multivalvular involvement which we classically see, and there is going to be an interplay of lot of factors here, and it is difficult to determine the exact stenosis or mitral valve area in such situations because of so much of complex hemodynamics which will be at interplay. So I just wanted to highlight that, look at the way, it is so difficult to actually planimeter in this kind of a subvalvular apparatus, which is 4+. There's hardly any mitral valve opening. The aortic valve is involved. So these are your run-of-the-mill, very usual cases which may not conform to your simplistic concepts in your day-to-day life. So I've already mentioned that MS can decrease the aortic stenosis gradients if there is, LV dysfunction, low flow state, and the gradients will be actually lower because high LVDP is there in these cases, and it can affect both the pressure half time. So the mitral valve area estimation by pressure half time will be more, and the actual gradients will be less as well. So it will underestimate the severity of mitral stenosis. Coming on to mentioning continuity equation, yes, it is relatively flow independent. It exactly the way you calculate the in aortic stenosis by continuity equation, you can actually use the LVOT area into VTI for the stroke volume divided by the mitral valve VTI. So that can also give you a mitral valve area. The limitation is that there is an inherent inaccuracy in LVOT diameter calculation, which is valid even for aortic stenosis. In AF, the mitral and aortic stroke volumes are different in different beats. And if there is an associated MR or AR, the continuity equation cannot be used in such cases. So it is not really recommended for routine clinical use. PISA, I had shown you initially that mitral valve area can also be estimated by PISA, just the way you do it in mitral regurgitation. It is again relatively flow independent, and this is still valid in the cases of AR-MR and correlates well with the cross-sectional area and invasive modalities. It is technically challenging. It may require angle correction because the mitral valve is usually very distorted, and again is not really recommended for routine use. There is a recent paper in 2019 that there is, just like you have low gradient severe aortic stenosis, you also have a phenomena which is known as low gradient mitral stenosis. So there are three subtypes. You have low flow, low gradient MS, which has poorest survival. You have high gradient MS, which has intermediate survival. And then you have a normal flow, low gradient, which obviously will have the best survival. Um, so not all is rheumatic heart disease, and I would like to mention mitral annular calcification in the elderly subgroup. So you can see very significant mitral stenosis, which is occurring because of mitral annular calcification. There is some MR as well. These patients also tend to develop thrombi on these mitral annular fibrotic or calcific areas. In these cases, we don't have any data that the pressure half time is reliable because the LVDP is usually high. These are elderly patients who have hypertension or age-related changes in the left ventricular compliance. And then you have the same patient, you can see the significant mitral annular calcification, some aortic sclerosis as well. And this is the same patient. You can see, so planimetry can come to your aid, and you can actually look at the mitral valve morphology, gives you much better idea in terms of the severity of mitral stenosis in these cases. Then you can have sometimes caseoma. You can see a huge caseoma attached, which is also giving rise to some significant MR and some stenosis of the mitral valve. So this is that patient of caseoma. There is significant MR and TR both. So this is that patient. So this is that caseoma, which you can see. This is the caseoma. And we have already mentioned that there are some other things that you should look for is the PA systolic pressure. Also look at the thickness of the interatrial septum, because when you're trying to do BMV, that can come in handy, especially when you've doing transesophageal echo. The last word about stress echo, it is again a very good modality in cases. It is a class 1 indication in ACC guidelines to evaluate the response of the mean mitral gradient in PA pressures when there is a discrepancy between resting Doppler echo findings and the clinical symptoms. So you may find that the patient's symptoms are significant when he's walking, but when you're actually doing a Doppler study, the mitral valve area may be 1.4, 1.3. Gradients may not be very high, but the moment you start making them walk, especially if we don't have bicycle ergometry, which is a much better modality. Otherwise, stress echo, you should use treadmill. Dobutamine has very little role in them. So you need a physiological exercise to unmask these patients who may require therapy. So the take-home message is that the grading of MS should combine the measurements of mitral valve area using planimetry and pressure half time in your day-to-day practice, and of course, the mean pressure gradients, knowing the pitfalls as we have discussed. And in case of discrepancy, planimetry still remains a reference method. And when possible, 3D guided measurements of mitral valve area is recommended. since it allows you a direct visualization of the valve orifice in multiple views. Thank you.
Excellent, Dr. Vinayak. I mean, a lot things to learn. I learned a lot today. I hope everyone also would have enjoyed such a nice presentation. So I'll take you to the question, sir. Your talk was as lucid as your singing is. So, so now there is a question from Dr. Vinod Vijan, who says he's from USA, but he's from Nashik. I don't think so. Nashik has been included in USA as yet. It still falls in Indian territory. I hope he means that he is in USA. Just in a lighter moment. Now, the question is that is there a need of reporting primary and a secondary orifice area by either planimetry or any other method, and by CW not treatable often by a by BMV? I don't understand what he. Are you reading, Dr. Vinayak?
Just check, please.
Should I read as it is written verbatim? Should you report both primary orifice area, planimetry, PW Doppler, amenable to BMV, and secondary subvalvular MS by CW not treatable often by BMV? So both may be very different. Should you report both?
No, so see, please understand that the concept of secondary orifice is more of for understanding purposes, that mitral valve gradients or say sometimes there is a discrepancy between the symptomatology and the mitral valve area or gradients that you're calculating, and that may be because of the physiological, the anatomical secondary orifice, which is the subvalvular apparatus. Subvalvular apparatus is what? It is a mesh of thickened chordae, papillary muscles, shortened chordae. It is irregular orifice. It is a physiological orifice that we're talking about because of the anatomical distortion, and you cannot planimeter it. So it is a concept which has been proposed that you may have the stenosis not only at the level of the mitral valve, but also at the subvalvular apparatus. So you must mention subvalvular apparatus in terms of, say, Wilkins score, or in terms of, say, severe, moderate, or mild subvalvular involvement, but you don't planimeter it.
Okay, so the question is that do you attach ECG? This is a broad question. On all patients, you do an echocardiogram. I would say that yes, we do, but not in current situation, COVID, when you have an ASE guidelines that you may not use ECG because you are unnecessarily making contact by making an ECG. So ECG can be given away in current situation, but otherwise you need to put ECG leads on every patient. You got to record blood pressure of every patient whenever you're doing an echo. That's something critical. What is mitral annular disjunction? I think the next talk I would probably take on Thursday on mitral valve prolapse, where it is relevant. Right? So Vinayak, you want to take anything? Is it something to do with mitral stenosis or other mitral thing also, is only for mitral valve prolapse?
Oh, which one? Sorry, I missed the...
mitral annular disjunction.
Mitral annular
disjunction, which is there in mitral valve prolapse. So I don't think so this has anything to do with mitral stenosis.
No, not at all.
Okay, there had been requests because a lot of people have gone to attend emergencies, and even otherwise, I don't think so once is enough to understand. We always read again and again, actually, at least in medicine, to know more. And in case this video recording can be shared on a later basis, I would request the organizers to do it.
Sure.
Is there any feasibility, Ranjit, Indresh?
Sir, we will be retelecasting.
All right, soon, that is a good idea.
Everybody noted, yes.
Perfect. So you can read again. At least I read everything 3-4 times
sure,
before
yes.
imbibe. We are still, this is from Sadak Khan, that we are still reporting MS severity according to older guidelines. taking a severe MS with the mitral valve area less than 1 centimeter square, and how to report severity according to the new guideline. Have you imbibed, or are you suggesting that we change now?
So what I tried to show was that if you look at the ACC guidelines, they have given a stage A, B, C, D, which is a functional classification, which is a
Yeah.
clinical classification for all sorts of valve lesions. I
All
think,
heart failure for that matter. I mean, the
or
same
for
thing.
heart failure, or for
Yeah.
any, that's the way we describe that at-risk patients, structural heart disease, and then asymptomatic and symptomatic. So A, B, C, D, that's how you divide the disease progression. It's that classification is based on progression. Why they took severe MS is less than 1.5 centimeters square is because the physiological or hemodynamic implications clinically come at a valve area of less than 1.5. But when we are actually looking at, say, decision making in terms of BMV, I would say we can do BMV at an area of less than 1.5 centimeters square if the patient is highly symptomatic. And if we do a stress echo and the PA pressures go above 50 or 60, then you know that this patient requires at least BMV. But the mitral valve replacement is still done when the anatomical area is very severe MS according to the ACC guidelines of stage ABCD. So per se, all that they've done is they have given a severe MS title to the clinical aspect. But I think we should you cannot report severe MS according to the so-called, so you have to mention the clinical part of the patient as well when you mentioning the ACC guidelines. You can mention both. You can say that, okay, conventional mitral valve area is 0.9 centimeters square, which is very severe MS according to ACC 2017 guidelines. You can also mention the patient is severe MS 1.4 centimeters square according to the ACC guidelines, moderate MS according to conventional guidelines. You can mention that. But most of us are actually not mentioning the ACC guidelines as such, because that is more of a clinical implication wise. We know that it'll help me in my decision making when I just labeling it as severe MS doesn't really change the way we look at it in echo.
Correct, correct. So there is Muhammad Arif wants to know. I think I'll little broaden up his question. His question is very relevant and important. It says mitral valve area, let's say discrepant that it's 1.8 and gradient is 14. There is a discrepancy between two. You know, most of us like visual ejection fraction would believe whatever you think is correct out of that and try to discard the other one. But I want to ask you that, you know, once you have a discordant reading, you know, what to believe and, you know, how to sort out this issue.
So we have already discussed that in detail, that if you have, say, very high gradient of, say, 14, mean gradient is 14, you must first look at the reasons why the gradient would be high. So most of the times the gradient will be load dependent. So you have tachycardia, anemia, thyrotoxicosis. Your patient may have AF with fast ventricular rate or whatever, which is giving rise to your high gradients. But planimetry remains your gold standard in such cases of discrepancy. But you have to remember that you must do planimetry with all seriousness. You have to spend time. I've seen people doing very casual, planimetry. You have to spend time cutting the tips of the mitral valve, especially when you have explain feature with you. So at least it will give you a pretty decent idea as to what is the morphology of the valve. If you have 3D, that can also give you a very good idea. So planimetry still remains your, say, reference frame.
All right. So Dr. Raju wants to know, I think there was an auto correction. He mentioned, is Lisa flow dependent? Lisa is going to mind. It's not flow dependent. He corrected it. It's PISA for a flow dependent. Why PISA is flow dependent, sir? Dr. Vinay?
Hello.
Why PISA is flow dependent? Can you hear Dr. Vinay?
Hello.
Dr. Vinayak? Am I audible?
Yeah, so you are audible. I think there is some.
Vinayak, audio issue is some with the.
Are you?
Yeah. I was asking you a question that why PISA is flow dependent.
Vinayak sir, there is a question on why PISA is a flow
is
dependent.
actually relative flow independent actually.
Yes.
It is not flow dependent, it is flow independent. And in fact, as a this thing, it is actually valid in the cases of ARMRs also. So I think, but the only thing is in MS, we are not really looking at PISA per se. It is very difficult technically to do in a distorted valve. How are you going to actually measure the hemisphere in a distorted kind of a valve? So I had mentioned one slide on PISA in this also, that you should, I mean, PISA is a good concept, but then you need an angle correction. The valve is going to be tilted, distorted. So it is not validated for day-to-day measurement of mitral valve area in these cases.
You showed an excellent case of mitral annular caseoma, and my mentor HP Singh from Amritsar and Dr. Aparna Thakur wants to know, can you just brief what caseoma is?
So caseomas, actually, we probably all of us will see this kind of a deposition of calcific material near the posterior annular plane, and it can percolate into the posterior LV wall, the entire annulus, and sometimes they can grow onto major, like almost like a tumor or a mass, and they are mainly degenerative processes, and very difficult to treat because the surgery wise, if you want to take them up, there is very little place to take sutures or sew the valve in those areas. So technically these are important issues whenever you have these cases, and in cases like these we don't have the validation of the pressure half time, etc. So your planimetry still remains the best bet that you have for determining the the severity of MS in these cases.
Absolutely. There you have so many fan followings, and they've been saying excellent talk, and many of them from outside India, Mexico, USA. That's very nice. There was one question of mitral valve resistance.
Yeah.
How do you use it, and what is the clinical relevance?
So I haven't used mitral valve resistance, to be honest, though it is written in the guidelines that mitral valve resistance can be used as one of the parameters to determine the severity. I haven't used it ever, actually, to be honest. And it is not recommended. I think it's more for the research purposes as yet.
Correct.
And we're not really using it. I'm not using it in my clinical practice.
If
Dr. UP has some, this thing on mitral valve resistance, I haven't used that modality.
No, I am not. I am not conversant with the mitral valve resistance. I think it's still a more research tool than a clinical application. So Dr. Monica wants to know, is it advisable to calculate PVR in cases there is a mismatch between mean gradient and PASP?
No, there is no recommendation of that at all.
So rest is an excellent talk. And in few cases, mitral valve area may be lower compared to that of gradient, which is relatively more. We've already,
We have actually given a lot of examples, and we've discussed that. The whole talk was on that only.
All right. I think more of them are compliments to you, sir. And there are questions, but I think for the paucity of time, let's call it a day. And thank you, Dr. Vinayak, and thank you, Indresh Ranjit from Philips. Philips has been very, very proactive. We have so many requests now from, Dr. Vinod Vijan also has given a very nice idea that why doesn't Philips arranges a 3D workshop for people, those who are using Philips machine and 3D. I think we can discuss that later.
Sure.
And it's over to the organizers. And thank you, Vinayak, for sparing your time.
Thank you, Chief, and thank you, Ranjit and Indresh. It was I enjoyed the session. Thank you.